This morning on Media and Society, we discuss the recently released HIV statistics and how the media can be an ally in HIV education and awareness. Well, hello and welcome to Media and Society. I'm your host, Naledi Mulong. Of course, this is the show where, as you know, we take a look at the intersection between the media and society. Of course, this show is not complete without your input. So over the next hour, feel free to give us a call. The number 011-714-0661 or 0662. Well, let's get into our discussion for this morning. HIV/AIDS remains a significant global health threat, particularly in South Africa. Now, despite significant progress in recent years, young people continue to be disproportionately affected, with an estimated 38% of new infections occurring amongst young people. But how does the media play a role in this fight? On the one hand, some argue that the media coverage has slowed down, and so you're seeing less HIV awareness campaigns, which has led to a decreased public engagement and a lot more complacency. However, others highlight the media's potential as a powerful tool for education, for destigmatization and mobilizing support. But this is the conversation we're having this morning. Give us a call, 011-714-0661. How do you feel the media is doing and faring at the moment in covering HIV and AIDS awareness in our country? 011-714-0662. Joining us to discuss this, we're joined by Dr. Thembisile Xulu, who is CEO of the South African National AIDS Council. Thank you so much for joining us. Good morning to you.
Thanks, Naledi. Morning to you and your viewers.
Really good to have you with us. We're also joined by Sibongile Nkosi, who is Executive Director at the Global Network of People Living with HIV. Sibongile, good morning to you. Thank you for joining us.
Thank you.
Right, and a popular face, one that you certainly have seen on the show before, Bonso Bilane, a media scholar, also a research fellow at the University of Stellenbosch, award-winning journalist. Good morning to you, Bonso.
Morning, lady.
Really good to have you with us, ladies. I think I want to start off with the basic question that I really am asking even to the viewers, right? Are we seeing a slowing down of HIV coverage, just across the board in your view, particularly when you perhaps, start to compare it to where we were 20 years ago, for instance?
Certainly, yes, because I think if you look at how globally, even from a global health perspective, what HIV is that, we've won the fight against HIV. People now have treatment. It's no longer a crisis. But also, I think there's a lot of intersecting health crises that are happening globally, even in South Africa, right? So the health crisis that we have around service delivery, which is recently COVID happened, and therefore, we saw a decrease in the coverage of media, a coverage of HIV, particularly thinking around there's so much that we've achieved.
Right.
Over the past 40 years.
So, Bonso, can I bring the same question to you?
I think there has been a slowdown, and the slowdown is for many different reasons, including the broken media funding system, right? We had Soul City, we had Pamukate, we had so many different series and investment in media 20 years ago into educating. We had fellowships for print journalists. We had scientists being trained on how to speak to the media on HIV in simple ways. We had so many different things on radio as well. But what we've seen, as Bongile said, with the increase in treatment, accessibility, and also in the longer lifespan of people living with HIV, we've seen us really resting on our laurels. And instead of really taking up the mantle and really looking at what the results are, the HSRC just released their results, and that is a bleak picture. The fight against HIV is still strong. We're trying to fight for 2030 to see no new infections, but we're nowhere near that. So I think with the lack of health journalism as well in newsrooms, where there are not enough, I sound like a broken record because I say this every time.
All the time.
There are not enough health journalists in media newsrooms.
Can we talk a little bit about what those numbers are actually looking like, right? Let's talk a little bit about what those numbers are looking like, because essentially what you've got now is we're getting 38% of new infections are coming from young people. What is happening? How is that even possible when we've got all these resources? And perhaps we could talk about how there's a lack of information and that's the problem. But let's talk about how that picture is still looking and who's most vulnerable at the moment.
So the global trend looks very similar to the South African trend, where we are, if you compare 2010 to now, there has been a global decline in new infections. We've got better treatment coverage and obviously viral suppression. But what is disturbing is that as much as the trend of new infections is coming down, it's not coming down in young girls. So when you look at young girls aged 15 to 19 and 20 to 24, their prevalence rates are 2 times higher than males of the same age.
Yeah, that means they're not getting it from the boys.
Then you look at the same girls, 20 to 24, and you look at girls, compared to boys, the females are 3 times more likely to be infected than their male counterparts. And then you look at the trends across men, as you were saying, across all the age groups, and you can actually tell the 40 to 44 to 45, same prevalence as the younger girls. So you can see who are the sexual partners of these girls. So it's a multiplicity of issues, like you were saying. Lack of access to information that is vibey and current and innovative for young people, because there are these presumptive approaches to education and awareness that don't make young people appreciate the level of risk that applies to them. Young people right now would not, if you ask them what's your primary concern, it's probably getting a job than getting HIV.
Money. It's money.
Yep.
You see, and perhaps that's where we need to take the conversation about what the media should be doing then to address the issues of young people, because it seems that what they're looking for is opportunity, and that's why you've got 19-year-olds being infected by 40-year-olds, right?
Yes. But I just want to speak because I come from the communities, and we have a different experience in terms of like how young people are responding, particularly because when you work with communities, we want to put in the issue of experience. And I think what health science does is focus so much on the numbers, but less on people's experiences.
Right.
And I'm just going to caution us as we speak about the infection rates. I think HIV, the biggest thing about it is that it has pathologized people, right? And we don't talk about people's experiences of HIV. Last week I was at a young people's conference, and young people are not going to the clinics, and I'll tell you why. They were saying, we are not going to the clinics because when I get there, I'm an HIV statistic. I'm not an HIV statistic.
I'm not a person.
Yes, I'm not a person. I struggle with stigma. So I'll tell you, last week we released a stigma index, a global stigma index report. And one of the things that's coming out is that people are internalizing stigma. And I think Ponzo is quite right that the media has a role in actually, where there's education, there's less stigma. But because the media has also left us when it comes to HIV, what you're seeing is people are internalizing stigma. So when you've internalized HIV stigma, people are going to run away from taking treatment. Young people are not going to want to listen to anything that has to do with HIV because it's highly criminalized, it's highly stigmatized. And if you look at where HIV is, it's amongst key populations such as young people that are sex workers, people who use drugs that are already stigmatized. And now you want me to add the addition of HIV. So there's quite a lot of things that are playing. And again, just going back to what the media does, if there's so much that is invested on communication, they would also invest in getting experiences of young people and not pathologizing and using too much statistics and science into the HIV response. And that is where in 2023 we are at. We no longer want to talk about, we know the stats. Now what we want to know is that how do we do it? How do we make sure that another young person is not infected with HIV and the young person who's infected with HIV stays on treatment? And that requires a multi-sectoral approach. It requires quite a lot of investment in different approaches, not just HIV science.
I want to stay with you, Sibongile, because you're making an interesting point around internalizing stigma. And I think what we do, particularly, once you've reached a certain level of knowledge, perhaps, from an academic point of view, we speak this way. But the young person who's possibly watching us right now, who is 21, 22, 26 years old and HIV positive and has internalized it, might not understand what that means, right? So how does internalizing stigma actually translate? What does that look like? If I'm a family member, how do I know?
So how do you get HIV? You get HIV through sex. Already sex is told through religion. You are told not to have sex as a young person. So we're talking about sexual health. There's no sexual health education in schools. So already I'm told that sex is bad. Then when I get HIV, I'm already shamed in society. So now I'm struggling with a shame that I am the one who actually caused myself to get a disease that is already shamed. And we can't can't run away that in the 90s there was a lot of stigma around HIV, and we're still seeing the stigma now. That's why a lot of young people are not coming out, right? That they are living with the disease. So therefore, then there's a shame of the sexual health, then there's a shame of HIV, which is a disease. And what does that mean? That might mean there's a lot of research that's showing people are lost to follow up in clinics. Clinics are losing young people because they are ashamed to go back, because even the nurse at the clinic is actually stigmatizing them, telling them that this is how you got HIV. So that's what internalized stigma is that they go back and sit in their little corner, and then they stop taking treatment, and then you reinfect others in whatever ways. But I think there's a lack of meeting young people where they are. If governments, if social scientists were really, really interested in understanding, then we would see quite a lot of research, and even the media, we would see quite a lot of stories that are human-centered. And I think Bonzo touched on this. There isn't a lot of funding that is going to do these stories, and these stories take time if you want to have a human. Now HIV is a World AIDS Day story, if we look at how HIV
and that's why we're having the discussion now in December, right? And we'll likely have it again next year in December. Bonzo, let me bring you in here, because I don't know where the lack of focus was. I mean, we could certainly say that over the past 4 years or so, while we focused on COVID, but even before COVID-19, HIV/AIDS, the conversation did slow down. I remember particularly during my youth, and you and I are around about the same age, we had, campaigns like 2010, Will You Be There? That kept HIV in the back of your mind as you engage in the things that you engage in. So maybe then we need to talk about what is the conversation that we need to be having once we do start it, once we say, okay, this is what the campaign should look like, because we've talked about, opportunity, and that's what we need to focus on. There's also stigma. It sounds like we're having the same discussions we were having in 2001.
I think, in the HIV activist space and just the general health activist space, there's a saying that says nothing without us, nothing for us without us. Are there enough HIV positive people in newsrooms? Are they being consulted? How many human-centered stories are there? Are organizations, and I might sound like I'm tooting my own horn, like the Soul City Institute for Social Justice, are they still getting money to have a drama series that's 45 minutes long on a national public radio television station? How much does it take to put a Soul City drama series season together? Right? How long? I used to be a health journalist. I reported on HIV. It doesn't take attending one press conference to write a proper story on HIV. It takes time. The stigma that Spongile is talking about, even the stigma that Dr. Xulu is talking about regarding who has HIV and how to get a young person living with HIV who's 18 years old, who was not born with HIV, to tell you their story is a 3-month process. But if newsrooms are chasing deadlines, if newsrooms are chasing the next story, we are going to see what we saw last week that happened in one of the newspapers in South Africa, where headlines said black women don't want to use condoms when they're supposed to be reporting on the HIV statistics from the latest HIV household survey. That's stigma to a group of people who are already vulnerable to HIV and vulnerable to other things such as gender-based violence, poverty, unemployment. So I think there really needs to be going back to the basis, listening to people who live with HIV, listening to the activists, listening to the research as well, but combining these things to tell stories that have solutions, to tell stories that educate, to tell stories that are beyond the sensational headlines that we still see with HIV reporting in this country so many years later. I think that what we need is a media and funders, people who fund media, who are invested in the well-being of South Africans and people who live with various conditions, including HIV. We do not see that. The media sector is in a state of an emergency, I would say. We're seeing newsrooms close down. I stopped being a journalist because the funding cycle just simply doesn't work. Funders are also supposed to be held accountable to not just fund what they are passionate about or what their strategic objectives are, but to listen to what works on the ground. We have the evidence, we have the experiences. Let's do it.
Bonzo, I know that you're going to leave us, so and Dr. Xulu, we're going to stay with you because we need to keep hearing from SANAC, because essentially what SANAC is going to tell us is if you're getting the calls from the media, as you should, but as a media practitioner yourself, Bonzo, I want to do this. Is it simply perhaps that the media practitioners themselves don't understand the importance of sharing the information? I think of, for instance, some of the research houses that we've got in our universities that are very academic, that have set themselves goals. There was the 90-90-90 goal, right? 90% of people tested, 90% of those test positive are on medication, 90% of those who are on medication undetectable. Brilliant goals, very academic. Right? Is that the issue? Is that perhaps maybe we have a skills deficit in our newsrooms?
We definitely have a skills deficit in the newsrooms. You can count the number of specialized health journalists in your hand in this country. They're no more than 10. And most of them have left newsrooms. So what does it mean for the people who are left? I'm not saying that our colleagues in the media who are not specialized in health journalism are unable to report on it. It just takes time to understand when you get a study, what are the questions that you ask about it? When you hear about a clinical trial for an HIV prevention drug, what are the processes of getting a participant to be interviewed? What does the echo trial mean? There's so much technical jargon, but I would like to flip it a little bit to the researchers as well. I don't think there is enough investment within research institutes on communications to make it easier for journalists to understand this information. A lot of the times in the sciences, when communication, we are just the forgotten child. When they want a poster, that's when the communications teams are called in. But when we actually, scientists need to be trained to be eloquent and speak in human about their science, but also that activists should be given a space where they're able to talk about their experiences in trials and not to be hovered by research scientists. And we do understand that there are processes that happen in the scientific field that require the researchers to be involved. But where are the people's voices when it comes to this research? And we used to have this. The TSC is celebrating their anniversary today. That is the blueprint that worked. And of course we can make many, yes, we can make many improvements to how they did it. But we have done this before. We have done it in a better way. We need to start doing it. And I think on the media perspective as well, it can't just be HIV. Black women, trans people in the queer community cannot just be seen as HIV statistics. They are human outside of that. So even when we're telling the story of a queer person living with HIV, a young black woman who is living with HIV, who is at risk of HIV, we need to see the human in it. It is so multifaceted, and it requires money, it requires attitude change, it requires investment from very different stakeholders. And all these stakeholders need to come on board, but nothing will happen without money.
The money has to be there, and I want to highlight what you've said about how there needs to be that connection between the work that's being done by our academics and our research houses and communication, because again, these are people's lives that are being impacted, and also it's such a waste of good research if we're not able to share that information with people. Ponso Pilane is a media fellow and joining us, a media fellow with the Stellenbosch University. She's going to leave us during this break, and we'll continue this conversation on the other side of this. Feel free to give us a call though, 011-714-0661. Welcome back. You're still watching Media and Society with myself, Naledi Molewa. We continue our conversation this morning. So data paints a grim picture. Young girls and women are disproportionately affected by HIV and AIDS. Now, factors like gender inequality, harmful social norms, and limited access to information are contributing to their vulnerability. Now, while some media efforts exist, they are clearly falling short in the efforts to drive change. So we continue our discussion about how the media needs to step up its role in bringing you information and coverage about the state of where we are with fighting HIV and AIDS in South Africa. Give us a call as well if you'd like to share your thoughts, right? Campaigns that you remember worked particularly well in South Africa, and what do you think can be done better? The number to call is 011-714-0661. We're still in studio with Dr. Thembisile Xulu, who's CEO of the South African National AIDS Council. We're also joined now in studio by Dr. John Blandford, who's Country Director for the US Center for Disease Control and Prevention, or the CDC, in South Africa. We're also joined by Dr. Phindile Nxumalo, who is a Principal Investigator at the Aurum Institute. Thank you so much for joining us. A good morning to you. I want to start with you. Please talk to us a little bit about the Aurum Institute and what the Institute actually does. I think it certainly is one of those organizations that we can afford to educate people about?
Thank you. Good morning once again, Naledi, and good morning to your viewers. Yes, so the Orem Institute is it's an African organization that really is working in the research space, but we also are in health programs. So our mission is really to take research into policy and then translate that policy into implementation and program. But really our goal is really to then improve the lives of people and communities, and I think communities becomes important in this year because of our theme around World AIDS Day, and communities, but then globally. So we are really involved in research. We do clinical and implementation research. We are also involved in health programs, that is really the programs that were being discussed earlier, where we are seeking to keep to find patients, to prevent patients from getting HIV, but to find patients and keep them on treatment, retain them on treatment, really working towards supporting the Department of Health to achieve those 95 goals that we spoke about. And then we are also really now looking at bringing together the patient, we call it patient literacy, just the awareness, the information that patients have. And to me this is interesting because in the previous segment we were really speaking about those gaps between what the patient knows, okay, but what we know as health professionals, the policies that are there. So there's very well thought out policies and frameworks that we have, but how do we then translate those and make them practical for the patients? So really we call it a patient literacy campaign, which is really to bring everybody up to speed about what it is they need to know, what is important, and the goal is really for healthier lifestyles for communities.
Yeah, this is what we were talking about before we went into the break. Look at all that work that's being done. Is it reaching people? Doctor, I'm going to come to you, and then you're going to really bring things together for us. We know that HIV and AIDS is such a big problem here in South Africa that the global community has put resources into helping us fight HIV. I mean, talk to us about PEPFAR, the work that has been done there, and the UU campaign, the work that the international community is trying to bring home.
Thank you. Yes, so PEPFAR, the U.S. President's Emergency Plan for AIDS Relief, has been working in South Africa for 2 decades now, and supporting the national HIV response, which is driven by South Africa. So we're a partner in the response, and CDC is part of that as one of the implementing agencies. I think what we've seen over the last 2 decades is the enormous transformation in the scale-up of treatment, the scale-up of prevention technologies, new prevention technologies, and the availability of those broadly. And so that they're freely available, widely available. What we need to do now is to assure, as we saw the numbers, as you discussed earlier, the disproportionate rates among younger women especially, we're not getting the necessary information and necessary technologies to all those in need. The U equals U campaign, or undetectable equals untransmittable, was actually a community-led movement. It continues to be a community-led movement where the activists, people living with HIV, teamed up with scientists, took what they knew about scientific knowledge of when someone is on treatment, achieves viral suppression, and maintains their therapy, keeps taking their drugs. Their viral load in the body will get so low that it will not transmit to their sexual partner. So undetectable equals untransmittable. And the risk is 0. And it's a profound effect. It has an effect at a population level with the 95, 95, 95 goals are really about getting the treatment levels up so high that the incidence of new infections will start dropping, which we're already seeing evidence of globally here in South Africa. But it also has impact at the individual level. And as your previous segment, we're talking about stigma and internalized stigma. The U equals U message is optimal. It's necessary. We need the media to participate with us to get this message out.
Yeah, let me bring it back to you, Dr. Xulu, because we're hearing about this brilliant work, right? You've got the academic research, you've got the resources coming in from from various parts of the world. The US saying, well, we've also dedicated resources, and we have this U+U campaign. It's seemingly not reaching people, right? Someone just called in, I'm being told now in my ear, that a caller just called in, doesn't want to get on air, but told our producers in the back there that he doesn't believe that HIV is sexually transmitted. Goodness. The amount of information that we need to be sharing there. Do you feel, as the South African National AIDS Council, that you are being disappointed by the media, that we're dropping the ball here when there's all of this work and we should be stepping up to make it easier for you?
Absolutely, Naledi. I think if you look at the National Strategic Plan that we've got out now, it's called the People's NSP because it's meant to bridge the gap between health facility delivery of services versus let communities lead, getting communities involved, because there are segments of society, whether based on vulnerabilities or inequalities, they don't get access to those health facilities. And that is a segment that we can reach through the media with information. 20 years ago, there was Komanani. At every street corner, there was a billboard. We don't have that anymore. We might not be as strong on social behavior change, communications, but the media can be our partner and allow us to reach those communities that might not normally seek that information from a medical source. So our journalists need to partner with us to be educated well enough so that they can be able to transmit the message. But to work in the context of communities, I think we understand the science, we understand the data, but we need to now work with communities and not treat them as end users, but to treat them as equal and strategic partners, because as I was saying, there are certain psychological, social and other mental issues that actually prevent people, including the policy and the legislative environment around criminalization. People don't get access to services, and these are the things that we need to keep on the agenda so that the HIV agenda does not fall off the table, and journalists can help us to keep that agenda.
So, Dr. Xulu, let me ask you this. As the South African National AIDS Council, one would hope that when South Africa wants to have a conversation on HIV and AIDS, you're almost the first place that we go knocking, right? What has that traffic been looking like for you? The media traffic. Honest and be as honest as possible.
I have had to create media traffic. Anything outside World TB Day and World AIDS Day. Maybe around TB and STI week in February. Otherwise, I have to create media traffic, and raise awareness on issues like people living with HIV are now living longer. It's beyond just HIV that I'm concerned about. They're getting diabetes, they're getting hypertension. So I actively have to create traffic outside December. We were saying earlier, it's December.
It's because of World AIDS Day, December, we have the conversation and it dies down again. I mean, and talk to me perhaps about the same question, right? As a research house, are you getting the traffic? Are you getting the media calling in and saying, what's the latest academic information that you've got with us to share with us about the epidemic and other perhaps medical issues that we might have?
Thank you for that question. I'd say no. It's really about creating the opportunities, and we try and structure our campaigns and our media and our communication around the health week, the health calendar. So we would then land on dates and opportunities that are really provided by the health calendar. Outside of that, we really do not have the opportunity to then bring in some data and some information about the programs. So it needs to change, I agree, because the dynamics are also different. We don't have to wait until it's December. Thank you, Doc, for bringing that up. We don't have to wait until there's pressure. We don't have to wait until there's a report that's just come out and has indicated certain things. We are at implementation stage, and we are seeing this. We are interacting with the patients. So a lot of the issues that came up about maybe the stigma, access to care, we are at implementation stage and we're interacting with the patients. So we are aware of these issues. It's just maybe the access to those platforms where we then communicate our findings and maybe programmatic support for the patients and the people in the communities.
I want to just give you a follow-up though. I know that a lot of the focus does happen in December.
Yes.
But I particularly remember that when we started having the conversation on World AIDS Day, I remember, the 1st of December being the day, okay, I'll go and get tested.
Yes.
Do we at least have in December a spike of people and of behavioral change? So where people are getting tested, is that died down in your view?
So in implementation, we have campaigns throughout the year, and really our goal is to get people tested early. So we need, let me put it this way, for us as a clinical team, what we want is early diagnosis so that we can have early intervention, and Doc mentioned that then we have prolonged lives. We have patients who have the lifespan that we desire. So we are really at campaign level every day. So we don't necessarily see a spike. We see activities that are leading people to certain campaigns and certain things, but in terms of testing doesn't spike in December. We are trying to have testing throughout the year. And that's really because our goal is to get people tested early, know their status early, and access treatment early.
Okay, so we are going to keep Dr. Blanford and yourself on the set, but Dr. Xulu, just before we release you, as SANAC, right, and you can talk to me about whether or not that same question, do you see some behavioral change, at least a spike of people getting tested for HIV in December, if at least the December campaign is working, right? And then your call to action to the media particularly, and across the board, print, entertainment. We've got local radio stations that are able to speak directly to people.
On the December question, Naledi, it's actually sad what we see. We use, for sexually transmitted infections, we use male urethritis as a proxy. So we look at how many men have had urethritis over the year. And the data that we saw in January 2023 was 37% higher than we've ever seen. So condom use has declined to levels that we've never seen, and we see evidence in January. January follows December. December is the month that people default on treatment because it's Christmas, they're home, it's fun times, and the STI data in January shows us that condoms are not being used. So we are not getting the impacts that we want in that particular festive season.
That means we're moving backwards.
Absolutely. We are not, this HSRC data didn't give us incidents, but we are aware of data that's showing us that we had in 2022 about 150,000 new infections.
Goodness.
And what's sad is that about 8,000 of those are in children. So children are also being left behind. Men are being left behind. Key populations are being left behind. So there are areas or segments of the community that are regressing. And as they regress, the progress at general population level masks the fact that they are not getting access to treatment.
All right, well, we're taking calls 011-714-0661. Anonymous is calling in from KwaZulu-Natal. Anonymous, good morning. Thank you for calling. What are your thoughts?
My thought is we've got all these medias in place, your TikTok, your all the social medias, Instagram, you name it. And if you look at the 2000s, most of them, they're on that social media, but you don't find anything teaching them about the awareness of HIV. So I think we've got the platforms, but we need to make use of them.
Yeah, that's a very good point, because that generation may not necessarily be so vested in mainstream media, but they live on their social media platforms, and that's where they need to be reached. Anonymous, thank you so much for giving us that point there. Dr. Xulu is, of course, the CEO of the South African National AIDS Council. It's been an absolute pleasure speaking to you. We hope that we will be hearing a lot more from you beyond just December, because the work certainly is important. We'll continue the conversation after this short break. Do stay with us. Welcome back. You're still watching Media and Society with myself, Naledi Mulo. We continue our conversation this morning about how the media is faring in continuously giving you the information, the education that you need around HIV and AIDS, prevention, or even just protecting yourself by taking your medication, informing you about the innovations that are available to keep us healthier and healthier, right? Are we doing a good job at bringing you that information? Why don't you give us a call and share your thoughts with us? The number is 011-714-0661 or 0662. We are still joined in studio by Dr. John Blanford, who's Country Director for the U.S. Center for Disease Control and Prevention, or the CDC South Africa. Back with us in studio on set again is Sibongile Nkosi, Executive Director for the Global Network of People Living with HIV, as well as Dr. Phindile Nxumalo, who is Principal Investigator at the Aurum Institute, right? Dr. Blanford, I'm going to come back to you, and we talked about this during the break, right? That a little bit earlier, a caller called in, didn't want to speak on air, but said they don't believe that HIV is sexually transmitted. And I thought, well, it seems the conspiracy theories are still out in the air, right? So there's obviously a lot of work to be done, yeah.
Yeah, we can't feed that. HIV is sexually transmitted, and most of the infections are transmitted through sex, also through injection, drug use, sharing of needles, and mother-to-child transmission. We have effective interventions, effective prevention interventions. I think one of the things we saw in the HSRC data that were released by SABC was we saw these higher prevalence rates among younger women. You spoke earlier about the fact that in some of these cases, the younger women, the virus is transmitted to the younger women through older partners, but also their peers. Women's biology makes it more efficient for a man to transmit the virus to a woman than a woman to a man.
Right.
And we need to understand that as well. So for men, young men, 25 to 34, only 66% of them are virally suppressed. So that means 1 out of every 3 men in South Africa living with HIV is not virally suppressed, either because they don't yet know their status, or they're not yet on treatment, and in rare cases are on treatment but not suppressed. But mostly it's because they don't know their status or are not on treatment. Those men are the threat to the younger women as well. And we need them to understand what the value of treatment is for a long, healthy life, but also that they won't put their partner at risk. If they have HIV and are on treatment and are virally suppressed, they will not transmit the virus. And we need to destigmatize HIV. People living with HIV who are doing the right thing, they're on treatment for their own health, but they're on treatment because they know they're not going to pass this on to the sexual partner. 0% risk. 0.
Yeah.
And for those younger women, we also have highly effective pre-exposure prophylaxis. And for those who are otherwise sexually active, 99% effective in reducing HIV transmission with daily use and daily adherence. So we have the tools. We were talking earlier about the need for people to go in and get tested. There's the needs for follow-up action as well. If you're HIV negative and you're sexually active, you should get on pre-exposure prophylaxis or PrEP. If you're HIV positive, you should get on treatment and learn the good news about U equals U and get to an undetectable status.
Yeah, you know what I found very interesting though about the era that we live in is that I remember when you first needed to go for an HIV test, you needed to go to the clinic, get some counseling first, then get the test, then get counseling afterwards. But it's so easy now. You can walk into a chemist and for 40, 30 rand, you can buy yourself a test. And I mean, it's the ease of what's available right now with some of those innovations. But we need to make people aware of it. We're taking your call, 011-714-0661. How's the media faring though, and keeping you updated on how we're doing in the fight against HIV and AIDS? Julian is on the line from the Free State. Julian, good morning to you. Thank you for calling.
Good morning, lady. How are you, man?
I'm well, sir. What are your thoughts?
No, my thought is there's absolutely not enough. Not enough is being done. You know, I was telling the producer now, but I went and did the course, the peer educator course, a few years ago with the Mangau Metro. And the certificate is just sitting there. I mean, we're not being absorbed into the system to say, well, you guys are qualified now, you can go ahead and actually, because we don't have the platform to go around, teaching about these things. And as I speak now, I'm living with the disease for more than 10 years. And, I know a lot more about it than actually the course I did, because I've been through the treatment of all the systems and everything. But we're not being absorbed. We're just sitting there with those certificates, and that's that.
So who's dropping the ball, Julian? I mean, if you have the qualification as a peer educator, you're a powerful tool in getting information to people in your own community and around you. So who do you feel is really dropping the ball for you? Julian, are you still there? Okay, Julia's not there. And I was going to actually ask him, why don't you get onto social media and start creating some of that content yourself? But here's the beauty of it. So you've got the skills, you've got people in the communities that are saying, we want to help and get information out there. The information you sit with and you generate as well from an academic point of view. Who needs to sew it together for you?
I love that. I love that he also speaks about his own personal experience and his own journey and showing interest in trying to see how they close the gap. I think we need the platforms. I think we need to actively create the platforms where the journalists and the scientists and the health experts meet, because we then are creating a reliable source of and form of information for the communities. We also are taking away the pressure, because I think what then happens in the healthcare facilities is there's an expectation that every point of information that's needed by the patient will be at that healthcare facility, at that visit that they are in the facility in. But you can imagine that we can always supplement that with the social media efforts, with whatever publications we have, opening lines like we have now and having people saying, I'm ready, I'm qualified, I'm willing to bring in the peer support. And we speak about young people. Young people will never listen to not never listen, but they would listen to somebody who's a peer more than they would listen. And I think they go to facilities and they are intimidated by, they get there and they feel judged. Some of them, I've seen them, they go there in groups because they are really scared to go there as an individual because they're just scared of the backlash that they'll get. So we need to encourage this culture, youth-friendly services, open culture, and not beyond that. Key populations, make them aware that they also have the right to the same healthcare services that they need. So just to get back to the issue of having a skill but sitting and not being able to come through, I think we just need to open the platforms where we communicate and we identify these volunteers. I'm even inclined to say, he says he's in the Free State, we need to look for other funded organizations that are working in the Free State that can use and absorb people who've got the skill. I think maybe it might not always be a job opportunity, but it could be a peer-led platform that can improve the retention. We speak about retention. Retention is really those people who've been on treatment, some for a short while, some for a longer while, and it's difficult to stay. I mean, it's difficult to stay on flu medication and be consistent. Imagine lifelong.
A lifelong,
yes. And then Dr. Kulu mentions that as they live longer, they then also have other comorbidities, and that makes it even more difficult because it's not just the HIV medication; it's everything else that they need to take. But they need to comply. They need to look after their viral loads, so they're virally suppressed, because this is how we, from the program side, see the success of the program. We see that this patient's on treatment, and for us to say this is a successful intervention, it's because they're virally suppressed. That's how we note our successes. So I think we just need to open those platforms, make them a little bit more formal, bring in the volunteers, bring in the experts, and just bring in the communities as well.
Well, look at this, and you talk about how we've opened the platform. The calls are streaming in, which means there is an appetite for the conversation. We're going to take one more. Anonymous calling in from Gauteng. Anonymous, good morning to you.
Morning, how are you, man?
I'm well, sir. Thank you for calling. What are your thoughts?
Right. You know, man, I think that people can go and test it if they want. But the problem is with the clinic. You know, the way the clinic are operating, it's not good. You can't go to the clinic to take for treatment, then you stay there for the whole day, or at least for 4 hours. I think that if the system, they can change at the clinic, then when you go to collect your treatment, it may be something like 1 hour. People can be encouraged to go there. You see, you can't go to the clinic the whole day. You say, like at Soweto, so you can go to the clinic, then you will stay the whole day. Then that thing that you encourage people to be tested.
To go, Oh, that's a good point. That's a very good point. So there's so many barriers, right? I mean, what do we need to be doing now then? And perhaps Dr. Blanford, talk to us about, Anonymous says, well, you've got problems with just access to healthcare. Right. So before we even start talking about, let's campaign and talk prevention, people need to access the services, right? What's the first touch point that we need to be having now that we've put COVID a little bit behind us? And we can say, let's focus on the health issues that we really need to be focusing on right now, right? What's the first touch point that we need to
I think COVID also taught us a lot. And what it taught was patients actually did fine not coming into the clinic. We were trying to keep the patients out of the clinics as much as possible in order to minimize the burden on the staff in the clinics who were dealing with COVID, but also to protect the patients who were living with, potentially, if not on treatment, a disease that affected their immune system. And so that was very effective. So we had yearly scripts. And we had up to 6 months dispensing. Multi-month dispensing helps the patient because they don't want to come back to the clinics. Physicians, I always joke, think their patients want to see them more than they do. And really the patients do fine with multi-month dispensing. So if you can get to the clinic, get enrolled on the services, and get virally suppressed, you can be decanted into multi-month dispensing and use external pickup points to pick up your drugs. And that's actually very helpful. But I agree with you completely. It is a challenging system to navigate at times, but the patients are actually quite good and quite good at adhering to their therapies, and I think we need to trust the patients.
As we get into 2024, we're just weeks away. Can we set ourselves goals here? I mean, Dr. Blanford's talked about great innovations that we can be using to get people to access healthcare. And we're about to close it off, Sibongile, and perhaps I think you're the right person to give us the if we're going to do this right and have a better conversation next year, this is what we expect, not just from communities, from the media, from everyone, right? And let's be, particularly even where government is concerned, where resources are concerned. What is it that you want to see in 2024?
I think as a person living with HIV, and as a person, I think as the patient, I'm part of the patients that they're talking about.
Yeah.
I've been living with the disease over 10 years. I just want to say that we've set the path. We've got a global AIDS strategy. You were talking about the 95, 95, 95. We've got the plans. We know what we need to do. I think now it's a matter of us coming together and actually doing the actions. I think the U equals U. When
U plus U.
U equals U. Actually setting the agenda for us. We know that when I take my treatment, I become virally suppressed. And I think even when you look at the successes in South Africa, right? The successes. I think there still needs to be a big recognition of how communities have actually been such a key center of the HIV programming. I think a lot of the time researchers, governments and everybody else forget that the communities are the ones that hold the people. The communities know how to lead the HIV response. And I think the World AIDS Day agenda, we've set it. We've said, let the communities lead. So I'm really asking my colleagues here to actually go to the communities and ask the communities, so how do we do it together?
Yeah.
And that's basically it. I think with the HIV response, we've got the successes, and Ponzo spoke about earlier on. We know the importance of media play, the funding. We need to challenge your PEPFARs to actually say, right now there's a big gap in terms of information, right?
Yeah.
We are seeing TikTokers, people like, there was a doctor, I think, on TikTok who pretended to be a doctor, but he did quite well when it comes to HIV because he was telling people about taking ARVs,
this is
right?
very
So
true,
there's a
yes.
gap. So there's always going to be a gap in terms of who feels that information. And therefore, I am actually asking the donors right now, who are the ones that put resources in HIV, that put money into communities, put money into media.
Okay.
We know what
I want to do this. I want to do this because we're running out of time, but I need to do this. We are going into the silly season and people get, we get a little bit silly around this time. We make some bad decisions. I'm going to ask you 3 words. A young person who's watching right now is excited because they're going to go to a party in the next 2 weeks and they're going to see this guy and whatever it is, right? 3 words that you have to say for them, that young woman who's going into the silly season. 3 words.
Oh, goodness, 3 words is hard.
I know.
I think I'm going to sum it up this way. They need to know their status, because if they know their status, if they're HIV negative, we've got an opportunity for those preventative strategies, including the PrEP.
Yeah.
If they're HIV positive, then they need to then take treatment so that we can get to a level. So know your status and then get into prevention or get into treatment, depending on what your status is.
Yep. Get tested, get on PrEP if you're negative, get on treatment if you're positive, and live a normal life.
Yeah.
Go and take PrEP. There's PrEP now.
Yeah.
As doctor said, there's PrEP now. So just go take PrEP. And it's not silly. Let's not, sex it's okay to have sex. All of us want to have sex. So they have the right to have sex. It's their sexual reproductive health, but they must take care of themselves. PrEP is available if they don't want to use a condom. But if they want to use a condom, they can still carry a condom.
Yeah. Dr. Blanford Pindile, thank you so much. Mongile, an absolute pleasure having you guys here. And it's been a really enlightening discussion. We hope that we'll continue it on social media as well. #SABC Media Society. And that's where we leave it. My name is Naledi. That's how we wrap up Media and Society.